case of gestational diabetes. 25 years old, Mrs. Sandhya, a homemaker by profession, residing in Kumari, the obstetric score of G2P1L1 with her LLP on the 24th of March 2023 and her EDD on the 31st of December 2023 at gestational age of 36 weeks, presents with the chief complaints of being detected to have high blood sugar on routine antenatal care, and now she is on medical nutrition therapy. History of present pregnancy. First trimester, patient was conceived spontaneously. Pregnancy was detected by urine pregnancy test following 2 months of amenorrhea. Dating scan was done and was corresponding to gestational age. EDD was found to be on the 31st of December 2023. NG scan was done at 12 weeks and found to be normal. Folic acid tablets were taken. Injection TT was taken. No history suggestive of urinary tract infections. No history of fever with rashes. No history of spotting or bleeding per vagina. No history of pain, abdomen. No history of exposure to radiation and drugs. Antenatal checkup till 13 weeks was done at Edecode PHC. Second trimester, quickening felt at 18 weeks of gestation. Iron and calcium tablets were present. An anomaly scan was done and found to be normal. The GCT was done at 24 weeks and she was found to have gestational diabetes mellitus and was started on medical nutrition therapy. No history of pedal edema, blurring of vision, headache. No history of burning situation. No history of pain abdomen. No history of leaking or bleeding per vagina. No history of raised BP recordings. Third trimester, fetal movements are well perceived. The growth scan was normal. Iron and calcium tablets are taken. No history of bleeding per vagina. No history of pedal edema. No history of pain abdomen. Menstrual history. Menarche at 13 years of age. She resumed her cycles 1 year before, and the cycles prior to her LMP were regular. Regular cycles for 28 days, flow for 3 to 4 days, changes 3 to 4 pads per day. No history of irregular menstruation. No history of dysmenorrhea. No history of passage of clots. No history of contraceptives. No history of PCOS. Marital history. Married at the age of 22 years. Second degree consanguineous marriage. Obstetric history. The obstetric score is G2P1L1. First pregnancy at the age of 23 years in the year 2021. Vaginal delivery at Veterinary Government Hospital. At 34 weeks, due to premature rupture of the membrane, baby weighs about 2.4 kg, is born alive. History of neonatal ICU admission for 10 days for breathing difficulty. Breastfeeding is done for 2 years and she is immunized till date. Past history, no history of hypertension, epilepsy, bronchial asthma, thyroid disorders, no history of past surgeries. Family history, no history of diabetes, hypertension, epilepsy in the family, no history of any bleeding disorders in the family, no history of twins in the family, and no history of children with chromosomal anomalies or birth defects. Personal history. The diet is mixed, appetite is normal, sleep is adequate, bowel and bladder movements are normal, no history of substance abuse and drug allergy. Now she is on medical nutrition therapy.
General examination. Patient is conscious, oriented to time, place and person, moderately built and nourished. Weight, pre-pregnancy weight 82 kg, current pregnancy weight 92 kg. Height 161 cm and BMI is 31.2 kg per meter square. No payload, no uterus, no cyanosis, no clumping, no lymphadenopathy and no pedal edema. Vitals, pulse 74 beats per minute. Blood pressure measured at right upper limb is 120 by 80 mm mercury. Temperature afebrile. Respiratory rate 60 breaths per minute. Thyroid, spine, breast are normal. Systemic examination. CVS, S1, S2 health, no normal health. RS, normal vesicular blood sound health. CNS, no focal neurological deficit. Obstetric examination, inspection, abdomen is longitudinally distended, all quadrants moves equally with respiration, umbilicus is central and everted, flanks not full, linea nigra and side gravitarum present, no scars, no sinus and no dilated vein C. Palpation, no local rise of temperature or no tenderness present, abdominal width 100 cm and symphysis fungal height 36 cm. Leopold manner. Fundal width, soft, broad, irregular mass, not ballotable mass, resistive of breach. Umbilical width, left side, smooth curve, uniform resistant well, suggestive of spine. Right side, small nodules well, suggestive of lymph bulbs. Pelvic width, first pelvic width, broad, round, independently ballotable mass, suggestive of head. Second pelvic grip, first pelvic grip is confirmed and hands are converging, suggesting that head is not engaged. Auscultation, fetal heart rate 142 beats per minute, heard at left spino-umbilical neck. Diagnosis, 25-year-old, second gravida with 36 weeks of gestation with single live intrauterine pregnancy, longitudinal live and cephalic presentation, present with gestational diabetes mellitus or medical nutrition test.
Before coming to the investigation, how can you say that it is a gestational diabetes? You have screened at what gestational age?
22 weeks.
What is the time you have to screen actually?
24 to 20.
Is the ideal time? Is the ideal time?
The first antibiotics.
What are the screening that is it just universal screening?
Ma'am,
What is meant by universal screening?
it's done for every pregnant
Why do you
woman.
want to do a universal screening for your?
Because insulin resistance increases in pregnancy and India is a diabetic capital, so you have to.
So anyway, all the pregnancy should be screened. How will you screen? Yeah.
The Indian government has a universal screening for all the pregnant women, irrespective of gestational age, in which we have a 75 gram of oral glucose in 150 to 300 ml of water or lime juice. We have going to infuse it, and 2 hours post-prandial, the values is measured, and if the value is more than 140 milliliter, then we have to consider it as gestational diabetes, and if the value is more than 200, then over diabetes.
Any other points which can say that the patient is diabetic? Because in your history, this patient is having a preterm history suggestive of a preterm birth, PROA. So actually, you should not begin by the 28. You should have in the first visit. What are the other investigations you will do in the first visit? Suppose it is a, what are the investigations?
HbA1c level should be monitored.
What is the significance of?
HbA1c level should be less than 6.5 grams per deciliter.
But what does it mean in the HbA1c?
It's glycosylated hemoglobin. It's whether in past 6 of
6 to 8 weeks. Actually, it is almost
Okay. Then urine examination,
If it is elevated, what does it mean?
pre-gestation diabetes.
Particularly, you haven't, this patient doesn't have much significance. And what the complication in the first trimester? This patient can have
Congenital malformations can happen in baby. Cardiac anomalies can happen.
one type of congenital malformations.
Cardiac anomalies in GSD.
Gestational diabetes or in pre-gestation.
It's more common in the over gestation or
Overt
pre-gestation.
diabetes. What is meant by overt?
It's present before the onset of
Yes,
pregnancy.
and you have seen the patient in first trimester, you can say that it is, even you can say that it is going to be a pre-gestation. Okay, if it is a pre-gestational diabetic, what are the anomalies or what are the conditions which can have for the mother or for the fetus? Let it be for the fetus. Is there any increased chance of abortion?
And abortion, miscarriage, and
Why there is an increased chance?
maternal hyperglycemia that can result in fetal hyperglycemia. It can result in fetal increased production of insulin, hyperglycemia of the beta cells of pancreas, result in fetal hyperinsulinemia. It can result in unexplained stillbirth, miscarriage, or any congenital anomaly.
Which are the congenital anomalies usually this?
Cardiac anomalies, VSD, tetralogy of Fallot, transposition of the great vessels, unit tube defects like spina bifida, anencephaly, holoprosencephaly, fetal
Is
agencies,
this a specific anomaly? Is a pre-gestational
sacral agencies of caudal
or
regression.
regression syndrome? That any other investigation? What is meant by NP scan?
Nuchal translucency scan. It's done at 11 to 13 weeks. It is taken the posterior neck, measure the nuchal thickness, and if it's more than 3.5 millimeter, it's diagnostic. We can diagnose Down syndrome, Turner syndrome, or congenital cardiac anomalies.
Okay. If it is, what are the other illnesses that the patient is having? What are the other conditions? Is there any infections in the first trimester? Is there any infection that is going to be a pointer for the diabetes?
Chorioamnionitis.
Is it chorioamnionitis? The first thing,
Urinary tract.
yeah, it is more common as a UTI. I will going to diagnose an asymptomatic bacteriuria. Asymptomatic means the patient doesn't have, what is the most important symptom of a UTI?
Early menstruation, urinary frequency,
Hesitancy. Okay. When you go for a urine routine examination, what is the difference between it is a pregnancy and a non-pregnant stage?
more than 10 leukocyte hypertrophy in a pre-pregnant
Or a non-pregnant?
non-pregnant ladies, and more than 5 leukocyte hypertrophy in pregnant.
Then this shows that there is high chance of infection for the UTI. Not only UTI, but other conditions like a vulvovaginitis. Candidiasis also is a problem. And another thing is, your patient already had a preterm birth, PROM. How would you account for the PROM?
Coronaritis is more common in GDM, so it may result in premature birth.
Okay. Then how are you going to monitor this patient? She has already reached 36. She has already reached 36 weeks. Isn't it? Your patient is at home or with you? You have admitted. Yes. You have admitted the patient, isn't it? Why? She is admitted. And because of there is preterm labor, what else you can do? One is you can score for a urinary infection. Second thing, you only said there is a preterm labor because of an ascending infection. What else you can do?
Fetal surveillance.
Not only fetal surveillance, can you do this thing, high-vaginal swab? And culture, and you can treat accordingly. Okay. Then anything else?
Rose can be taken.
Okay. If she comes at 28 weeks, what will you do? Growth scan at what time to begin with? 28. Then every 4th week, if there is no other complication also, you have to go for a growth scan every 4th week. What is the other complication? If it is a diabetes, usually it is associated with other complications for the baby.
Fetal complications, miscarriage, macrosomia, congenital malformations.
Macrosomia means what?
The baby
By
is
definition.
more than 90% normal
For that particular?
for that particular population.
For Indian, this thing, it is
3,250 grams.
but it is almost 3,003.5 kg and more recorded as a. But ideally speaking, it will be more than 4 kg or 4.5. Sedation. If it is macrosomic, what will you have? Another complication.
So that's
Usually the patient during delivery, especially if this patient had a vaginal delivery, that was a preterm delivery. Sedation. Now she is going more than 36. What else you can do to prevent or what is the other complication for the baby? Can have the baby.
unexplained stillbirth,
Why this unexplained stillbirth?
in uterine hypoxia, due to
That is the mainstay. That is uterine hypoxia due to so many causes. You have the hypothesis. What is the hypothesis called? Anyway, there is a hypothesis. There is a, yeah. By that, there is fetal hyperglycemia or maternal hyperglycemia is the cause for everything. Sedation. For all the complications. If maternal hyperglycemia is there, it produces what?
fetal hyperglycemia.
Hyperglycemia.
Fetus cell.
This, the glucose, insulin can cross to the placenta. Does the placenta? No, it doesn't cross. So if there is maternal hyperplasia, then directly the glucose will be going to a baby and produce a fetal hyperglycemia. Because of the fetal hyperglycemia, what will happen?
The insulin cells of the beta pancreatic cells of the baby will be proliferating and then hyperinsulinemia.
Hyperinsulinemia produce what? Hypoglycemia. That is problems. What are the problems? Other problems can have.
Fetal growth restriction,
Which type of pregnancy you will have a fetal growth restriction?
overweight gestation,
Over diabetes due to what? Vascular. Because when there is associated preeclampsia or when there is vasculopathy associated, you will have all the complications of a. If there is a vascular pathology for in case of this diabetes, there is a pre-gestational diabetes. Mostly the baby will be, that is the answer. If there is a diabetes, it is going to be a big baby. Sedation. Whereas if there is an IGR which is associated with the diabetes, of course you have to go for two things. One, it can be an abnormal baby or it can be the patient with a growth restriction. What are the other associated maternal cause, maternal complication? Is there any association with
preeclampsia, polyhydramnios, infectious poliomyelitis, puerperal sepsis, increased risk of operated delivery and genital tract trauma.
Genital tract trauma. So coming to the baby, how do you manage for this patient? Your patient is there. How are you going to manage in the hospital?
She's on medical.
You already said that the baby is at risk for a stillbirth or an acute. How are you going to monitor that?
Periodically. Anti-medical surveillance includes
Kick charge. Have you had a kick charge? How will you explain that to
fetal
them?
movement should be monitored. After me, the patient should be on left lateral position and fetal movement should be counted for at least 1 hour. More than or equal to 3 fetal movements for 1 hour.
Previously, we used to have the cardiac count, but nowadays it is what this is because it is a high risk patient, this stage. Then what is the medical nutrition? You said there is medical nutrition therapy, isn't it?
Medical nutrition therapy, we have to give split meals in three meals and 3 snacks. Recommended calorie intake for obese patients, our patient is obese. We have to recommend a calorie
What is the BMI of this patient?
31.2 kg.
That means she is an obese. She belongs to the obese category, isn't it? Okay.
Recommended calorie intake of 24 kilocalories.
What is normal weight gain during pregnancy?
Normal weight gain 11 to 12 kg.
Because she is an obese, how much she can? The obese patient can have much more or much less?
Much less weight gain.
Yeah, how much?
7 to 11.
How much she is it? That's 10 anyway.
Recommended calorie intake for our patient is 24 kilocalories per kg per day. Carbohydrates of 40%. Low glycemic index should be given.
Once then let it go, say 1 or 2 with low glycemic.
Barley, millet, green leafy vegetables, spinach, fruits.
So you have to avoid all the high
High glycemic,
like white rice.
processed potatoes should be avoided. And protein should be 15 to 20%, at 60 grams per day should be given. Fat 20 to 40% of balance polyunsaturated and
Fat,
fat.
what type of fat?
A balance of poly and non-unsaturated fat. Saturated fat should be avoided.
Saturated is not good for them because they are going to have a much more complication. Any other cardiac problem is of the
Cardiomegaly, hypertrophic cardiomegaly.
hypometrophic cardiomyopathy, then I don't know, can or something like that. Biotic illnesses, sometimes it can achieve insufficiency or doing for cardiac, it's very rare, isn't it? And hypertrophic exhibition is on everything. What is the criteria for that? How will you monitor means by fasting those?
Monitoring fasting less than 95 mg per deciliter, 1 hour less than 140 mg per deciliter, and 2 hours post-prandial less than 120 mg per deciliter.
When will you do that? After 1 week or 2 weeks?
After 2 weeks,
Ideally,
is in control, we have to continue in medical nutrition therapy. If it is not controlled, we have to switch to insulin.
even if she is not well controlled, you have to start her own insulin or together with your isn't. Okay. Then if it is controlled, it can go up to
39 weeks.
39 weeks because
No other complications.
because she had a previous history of a pregnant vaginal delivery, it is better to deliver at term. At term means by nearly 40 weeks or just before, after 39 weeks. Because one of the most dreaded complications these babies can have will be respiratory distress. What is respiratory distress?
Respiratory distress is due to decreased circulatory infection and decreased hospitalization level.
There is delayed appearance of your so to accelerate the language, you can give anything for your patient. What type of corticosteroid patient need?
Beta microsome of very little of 10.
Now there is a preference over beta or dexa. Now nowadays.
12 milligrams, 24 hours apart, 2 doses.
Yes. If it is Pexa,
6 milligram, 12 hours apart, 4 doses.
what will happen to the diabetic status? If you give a shot of,
Result in hypertension. We have to improve the.
so if those patients on insulin may require an additional dose of insulin. If she is not controlled, say after 1 week, the patient is having a blood sugar, the fasting comes is 110, or the PPP has come out was 160, then how are you going to treat it?
With insulin.
Yeah, it is the insulin, not the weight. Isn't it? Insulin. What type of insulin actually?
Rapid acting insulin as part of this pro.
This is the first one. What is the one which is usually used here? That also can be used because it has a stringent action, and the time which can be given is immediately prior to the meals, just prior to the meals. Your regular insulin, what we are giving is just it will take 30 minutes, but you are in this pro. That's what that will take 5 minutes of sedation. So instead, having a look extra, what is the requirement in Sabri if I calculate the insulin requirement?
According to PV post-meal glucose values, we monitor for
How will you monitor? At least
Fasting.
for 4 times at least. One is the fasting blood sugar,
post-breakfast,
post-breakfast,
post-lunch,
post-lunch,
post-dinner.
post-dinner. And if the 3 are maintained, and it should be, the fasting should be less than, if somebody is on insulin, her blood sugar should be between 60 to 90. Isn't it? And for postprandial should be 140 or 120. Okay. It should be a stringent control. It should not be more than that. And once the patient is on insulin, the patient should be delivered after 38 or 39. If there is no other complication like a hypoxia or this thing or a hypertension, there is no other complication, you can deliver after 38 or 39. Usually it is on insulin, it should be after 38 weeks of gestation. If you want to deliver, depends on the prior history. If you want other complications, if you want to deliver early, that should be with a pre-dose of your corticosteroids. You should be given. Send it. Should be. What are the other complications that can happen to the fetus during the intrapartum? How will you go? For your patients with second trimester, she has a vaginal delivery. Or if she is 39 weeks, how are you going to deliver? You want a vaginal delivery or
Vaginal delivery.
how will you assess whether the patient can go for a vaginal delivery?
Cardiac photography.
Is that for vaginal delivery?
Vision scope.
There is a scoring system called the Bishop score. With that, if it is a favorable, means how much is the favorable? If it is more than 6, you can go for a vaginal delivery, isn't it? Intrapartum, what are the management strategies?
Our patient, there is no requirement of any intrapartum insulin or viscose infusion. In patients,
Not insulin. This patient anyway, she is actually established in labor. And what are the complications the postpartum period the baby can have?
urinary complication, hypoglycemia, hypothermia, respiratory distress syndrome, polycythemia, hyperbilirubinemia, hypertrophic syndrome, birth trauma.
Birth trauma. Because usually it is the baby which is going to be awake, and you have to have the shoulder dissociatory also. Because even with a smaller baby, the baby can get 3.25 or 3.5 kg, less than 3.5 kg, also the baby can go for the placement. So the birth trauma, usually this type of birth trauma.
Shoulder dissociation cause breast palsy, umbilical palsy, fracture of clavicle, fracture of humerus.
And the dreaded complication the postpartum period is when it is associated with the baby, can go for a postpartum cell.
Postpartum disease.
I think it is a nice presentation.